Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
And we're live.
Yeah.
Welcome back to the Cribsiders, everyone.
Hey, y'all.
What's up?
Justin Burke here, joined tonight by Dr. Krista Chu Manchu and our phenomenal producer, Dr. Becca Raymond Colker. Becca, how's it going?
Oh, it's going great.
Great to have you back. Our guest tonight, Dr. Margaret Scheffler, here to discuss medication safety, a great pearl-filled episode of tangible things you can do in practice, whether outpatient or inpatient. But before we go into the content, hey, Chris, can you tell us about the show?
Yeah, we are the Pediatric Medicine Podcast, where we interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
Tonight, we have a fantastic conversation with our guest, Dr. Margaret Scheffler. Dr. Scheffler is a board-certified pediatric intensivist who has been attending in the ICU and pediatric sedation service of Hasbro Children's Hospital since 2012. She completed her residency in pediatrics and her fellowship in pediatric critical care medicine at Texas Children's Hospital and Baylor College of Medicine in Houston, Texas. What up, Texas? As an AMS faculty member, she works with medical students, residents, and fellows to educate about the care of critically ill children, and her scholarship is focused on safe and effective uses of medications in children, including quality and safety improvement for medication use in children and determining pediatric-specific pharmacokinetics of medications used in children. Tonight, Dr. Scheffler teaches us life-saving pearls that you can use today to prevent medication errors.
So without further ado, I guess we should get to it. I don't have a pun.
You don't have a pun? That's a tough pill to swallow.
Is it? I don't know what
But what's the dose of that pill?
All right, so we can go ahead and get started, and we today are welcoming Dr. Margaret Scheffler to the Cribsiders. Mag, welcome to the show.
Hey, thanks. I'm so excited to be here.
We are very excited to have you. We already went through the formalities, but I want to do it on air. Is it okay if we go by your first name and refer to you as Mag throughout the show?
Yes, absolutely.
Thank you. I feel like we're old friends now, already on the first name basis. Obviously now we're on the first name basis, we're super close, but our audience would love to get to know you a little bit better. And so I would love to hear you kind of give yourself a one-liner, describe yourself to our audience. What are some things about you and maybe something that you're interested in outside of medicine?
Yeah, so I am a pediatric intensivist at Hasbro Children's Hospital in Rhode Island. I don't know if I should say my institution or not. I'm a New Englander, though I trained in Texas, so I was at Baylor College of Medicine for 6 years for residency and fellowship, but came back after marrying and having my first child, and I have 3 kids now. And so outside of being an intensivist, I am a busy mom. And then this past summer, the entire family got super into shore fishing. So now we all have fishing licenses and our own rods. Yep, our own rods and reels, and are big into fishing and pretend that we are successful at it.
So shore fishing presumably is fishing from the shore as opposed to a boat, but like ocean water fishing, and that requires a license. What do you catch from the shore?
Catfish. You can catch, so there are a bunch of ponds and lakes both in Rhode Island, I think all over New England, honestly, but Rhode Island and Massachusetts that they stock. And so at various seasons, you can just go and catch trout or catfish or other stocked. We actually went fishing in Roger Williams Park, so not too far from the zoo. It was like right in the middle of sort of an urban kind of area, but in the park, and caught little sunfish like things. And we are catch and release, so we just toss them back in there. But most of the time, you're not catching anything. You're just standing peacefully on the shore with some boots on in the water, enjoying the nature and the weather, and it's so relaxing. So if I catch a fish, I get excited, and that's a thrill also. But peace that comes with just standing there and admiring the nature for like 3 hours is unsurpassed in my experience.
Nice,
That's amazing.
nice.
Yeah, that sounds nice. Maybe I'll get into shore fishing.
Have you ever heard of the Japanese form of fishing called tenkara?
No, how do they do that?
So it's a long, flexible pole, and the pole is about the same almost the same length as the line,
Yeah.
and it's sort of it's a fly fishing type, but there's no reel, and it's great because you can just carry a rod around. I have one that collapses really easily, and you can just pull it out and just go fishing quickly. You don't have to worry about all sorts of things, and you should look up tenkara fishing. I bet you if you do some couple YouTube videos, you get hooked.
I would love that, because absolutely the next step is to figure out how to learn how to fly fish, because I saw someone doing it where my husband and I were fishing last, and it looked amazing and even more peaceful. So I was like, yes, that's what I want to do. And you can take classes through like LL Bean and stuff like that. So it's going to happen.
And the one that Chris has is portable. I mean, he'll take it out, at the restaurants, just anywhere, walking around the street.
Well, it's meant for like Japanese businessmen who want to just do it in their lunchtime.
That's amazing.
That's so cool. Yeah.
Good pick
No,
of the
I'm
week.
definitely I'm gonna make a note. I'm gonna look it up.
Tenkara.
Awesome.
Excellent.
Wow. So I could keep asking you questions about fishing. I'm super intrigued. But I'm going to pivot. And I'm on vacation this week. It's a rare feeling. I got some books lined up, but what is a book that you think every physician should read, or every person should read, or just a book you liked?
Oh my gosh, there are so many books this is hard. You should have emailed this in advance.
Oh, sorry.
It can be
my
any
bad.
book. Just name a book that you saw once. It can be.
You saw it.
One fish, two
So,
fish, three fish, blue fish.
One of my favorite books, one of my favorite authors is a guy named Mark Halperin, and he wrote a book called A Soldier of the Great War, which is all about he's explaining his life being a soldier and what came after to a younger man on a very long bus trip across Italy. He also wrote a book called Freddie and Frederica, and in his books, everything is very hyper-realistic, and his grasp of language and his ability to carry the narrative forward and keep your interest even without a lot of dialogue is pretty amazing. But he always has elements of the fantastical in his books. And so he'll start telling this story and it's hyper-realistic and you're getting into it and you're hooked in, and then it just veers off in this direction that's completely incompatible with the laws of physics, and you just buy into it. You completely suspend disbelief and buy into it, and it turns his novels into really, really fun escapist reads, but also really emotional because he gets you involved in his characters' lives so well. So I love his books. And then for nonfiction, I just finished Isabel Wilkerson's Cast, which was also a really great read, and you guys have probably read it already or heard other people talking about it. And she gave a talk that I attended and was, she was a very well-spoken person. And then when I read her, she's just an incredible journalist and author too. So even though it's heavy, sad stuff, it goes really quickly and is also still very engaging and educational. So Mark Halperin, the author, and pretty much anything he wrote, and then Cast by Isabel Wilkerson.
Those are awesome recommendations. I actually have not read either of them, so this is very helpful for me.
And then Sally Thorne for trashy beach reads.
Okay, added into the list. Love
Yeah.
it.
Wow. I guess my question I like to ask is, what is your favorite failure and what did you learn from it?
Oh, my favorite failure is the fact that I failed to get into medical school the first time I applied. And I don't know that it's my favorite. There have been so many now. But the thing that I learned from that is that, first of all, it taught me just how much I really wanted to go. I think sometimes if people tell you that you can't do something and you are maybe on the fence, it helps you hop off that fence in one way or another. So I had friends from college who also didn't get in, and then they sort of found a different path. And I didn't get in, and I was like, but wait, no, that's the thing I'm supposed to be doing. I really meant it when I applied. And so I really buckled down and nose to the grindstone and did extra academic work and extra volunteering and anything I could do to make myself look like an attractive candidate. And so that I did get in the second time, and then it was great for me. I know this doesn't happen to everyone. I was so lucky. I showed up to medical school and realized going through medical school that it had been the right decision. And then I showed up to pediatric residency and was like, oh, thank God, this is the right discipline, because probably you've all met folks by now who showed up and were like, oh, oops, like I had a friend who was a med peds resident who halfway through residency was like, actually, I think I'm an ENT guy. And I met an orthopedic surgery resident who was like, I actually want to be on the other side of the curtain, and changed disciplines and went to anesthesia. And so every step of my career, I've been lucky enough to show up at residency, at fellowship, at my current job, and at my current institution, and be like, yup, this was the right call. I'm in the right place, which is so lucky. I just don't think that most people get to have that direct of a path after, a little detour through, no thank you land, when they said, you don't get to come here.
I mean, it's so important, but even like for your friends who at least realize that they were in the wrong specialty, that, don't be afraid to go and make that change and be happy. I think that's also a good takeaway.
Oh, absolutely. I counsel, at every level when I'm counseling, if it's like college students or medical students. I was talking to someone the other day when she was trying to figure out how to rank her match list, leading up to the match. And I was like, they sell it to you like this path set in stone, and it is just not that. And if you go and treat it that way and sacrifice your ultimate destination to satisfy someone else's idea about, whether or not there's going to be a gap at the call schedule if you change disciplines, that you will just always regret it. Whatever, it's such a difficult, as you guys know, it's such an onerous path. It takes so long and so much energy. If the job you get at the end of the path isn't what you wanted, then none of it is worth it. And so I know so many people who've taken detours, who left residency for a different discipline, or even the same discipline but a different program, or left fellowship for a different discipline, or to become generalists instead of subspecialists. And it doesn't set people back. I think there's a fear that there will be a punitive result if you do that, and I have just never witnessed that. And everybody who ends up getting the job that they really wanted, as opposed to the one that they first went after, is so much happier.
Yeah, part of the path. The obstacle is the way, kind of thing. Yeah. Yeah, I think that's great. This is a very inspirational start, and I appreciate you sharing. And I think that it's nice to hear narratives from people who have found significant, enormous success, and kind of the path that led them there and got them to a happy part where they're enjoying everything that they do, which is really great and really great to hear.
Yeah.
Let's dive into some content. Let's do it. Becca, you wanna start us off?
Yeah, so I think, I generally like to start with a case, but first we just got to kind of like address the elephant in the room, which is, Meg, you pitched this topic to me months ago when I was on my first rotation of intern year in the PICU with you, and you were like, let's do an episode on medication safety.
Yeah, the sexiest topic known to man.
Yeah, like is this a boring topic? Should everyone go to bed right now? Like, what does medication safety mean to you? Like, why did you want to talk about this?
Oh, I wanted to talk about it because it is so complicated and so pervasive, and at the same time, or the issue of getting it right is so complicated and so pervasive, and yet so subtle and below everyone's radar. The fact that we're getting it wrong so often is not discussed enough, in my humble opinion. So no, people should not go to sleep. People should listen. Someone that I was talking to recently said it best when she said that for us, medicines are our scalpel. And I've said things like kind of like that in the past, where we're not going to be the wrong site surgeon. We're not going to be the person who fails to mark the right place and puts a piece of plastic in the wrong place, or most of us won't. But what we do every day is prescribe medicines for kids, and it is so complicated, and I don't think we acknowledge or give it enough credit for how complicated it is, and we get it wrong. I mean, not 100% wrong, obviously, thank God, but because it is so complicated, just getting one or two elements wrong is enough to really put somebody in harm's way. Medication errors, inpatient or outpatient, far outstrip for pediatrics any other healthcare associated error. I mean, it's just not even a competition. It's, number 1, 2, 3, 4, 5. And so when I started learning about it and learning, first of all, just how often it happened, which is scary, but also how complicated it is and intimidating it is for people try and get everything about it right. It really, first of all, I got really excited about it, really nerded out on it. And then any opportunity to talk to people about it and give them some simple ideas for things that they could do, like start doing this today and you will make your patients safer. Isn't that nice? People don't have to tackle the whole system, but I would like people to take a little bit more responsibility for their part of the system. And so that's why I was like, ooh, a new outlet to talk about this super fun thing.
I love that. And I think, a lot of what we love to do on this podcast is try to, talk about big topics, but boil it down to what are some practical takeaways that at any level of training or practice that you can bring to your practice to enhance your care of patients. And that's really exciting. So let's just talk about a case first. So we have Millie. She's a 3-year-old brought into the ER by her parents, the Grahams. And both parents are very concerned because for the past 2 days, Millie had a fever that won't budge despite giving her around-the-clock medicine. Aside from the fever, Millie's been overall well and just exhibiting some, sniffles, little cough. So, aside from all of the diagnostic questions that we might ask, a patient coming into the ER with some, fever and some, mild upper respiratory symptoms, how might you address the concern of a fever unresponsive to Tylenol and ibuprofen?
Yeah, so I'm not personally that afraid of fevers. And so even before I talk to families about medications to control them, I usually try and normalize it a little bit. The fever is your body's normal response to getting an infection. And so the body is doing what it's intended to do. But obviously persistent fevers make kids really uncomfortable, and it's difficult to get rest and participate in, daily activities. And so in that sense, it's important to try and keep the kids from getting too miserable. And then I guess we won't get into what would happen if this persistent fever lasted, beyond 5 days or something like that. Another episode. But obviously there's a chance. I would have two big concerns from that story. The first concern is, around the clock medicine, if it's being dosed correctly and the fever really isn't responding or going down, would have me thinking that maybe this kid is a little bit sicker than other kids are. But then the second big concern is around the clock medicine is really hard to do correctly and safely. And especially if you're trying to do what a lot of families have been counseled to do, which is alternate acetaminophen and ibuprofen and give one of those things every 3 hours. In fact, there's research, evidence-based, there's research showing that kind of regimen where you are trying to alternate medicines and give something every few hours is an independent risk factor for dosing errors and a medication adverse event. The other thing that's an independent risk factor is if you have more than one caregiver trying to give medications. And so if both grandparents are trying to keep on top of Millie's fever and neither of them are quite certain which medicine has been given most recently, then that's another independent risk factor for somebody getting overdosed. And, we're lucky that most medicines used for children have sort of large therapeutic windows and can be forgiving, but not always for sure.
Can I ask you, evidence-based follow-up, the alternating medication causing medical errors, is that, I assume, in the outpatient setting specifically?
Yes. Yeah. So there are problems on the inpatient setting with transitions of care. And so if you start a regimen like that in the emergency department and the patient stays in the emergency department longer than you anticipate, or maybe they go to an observation unit and are there for 12 to 18 hours before they get admitted, transitions of care introduce error too. And so it becomes critical that the person who's been administering those medicines, either over a shift or over a couple of shifts, correctly transfers the information to the person accepting care for that patient, so nurses typically, so that the nurse who's picking up the patient will correctly understand which medicine is next available. So I think it can absolutely happen on the inpatient side, but for sure on the outpatient side, it's one of those commonly recommended or discussed strategies for children that is also really ripe for error.
So what would be your suggestion as an alternative to suggesting that?
So again, I think if we can sort of normalize, I think, the safest thing is to minimize as much medication exposure as you can. And so if you can get families if you can understand how the fever curve has been going, reassure yourself that it's not curving in a dangerous or a direction that makes you think of a red flag, and instead just kind of normalize it. Like, I think this really is consistent with an upper respiratory infection, as opposed to, wow, that's strange. Maybe this is an upper respiratory infection that's now gotten complicated by an otitis media or a UTI or something like that. Then saying, it's as long as she's acting pretty well and eating and drinking well, and she's going to not feel great, and she's going to be taking time and not be as plateful as you're used to, but and maybe you want to try and control the fever at night so she can sleep better, but really let's see if we can't get by with just one of these medicines. Which do you think works better for her? Most kids respond better to one versus the other. My kids, for some reason, were never big acetaminophen fans, but I also didn't give them a lot because of exactly what I'm describing to you. I'm like,
hashtag team ibuprofen, yeah.
Right.
Sometimes it depends which flavor you could find.
I know, like, they were
I have one kid who likes bubble gum, another one who likes grape, and so like which one's the grape and which one's the bubble gum I have in the shelf. So
yeah, exactly.
There's a lot of variables in these medications.
Mm-hmm.
Well, I was just one of the things. I'm sorry, back up, please.
We were like both excited. I want to hear what your next question is, Justin.
My next question was as scripted, talking a little bit about weight-based dosing. I think, especially coming from a med peds background, switching from medicine to pediatrics, that was one of the most challenging things. Especially when sometimes I think a lot of med peds residents pick up on this, the pediatric dosing for things like ceftriaxone or prednisone or albuterol. Sometimes the weight-based dosing goes above what we're traditionally doing as adult dosing.
Yeah.
And I imagine that this is a ripe area for medication error. I don't know if that weighs out in the evidence, but yeah. Can you talk a little about weight-based dosing and complications, or how you counsel on weight-based dosing maybe?
So obviously weight-based dosing in theory or generally and typically is safer. So a tiny baby should not be getting the same dose as a 50 kilo 14-year-old. And so weight-based dosing is absolutely mandatory in that regard to keep children who are at different ages and sizes and developmental stages safe. It is interesting that, yes, sometimes weight-based dosing will exceed the adult dose. For that reason, most children's hospitals now actually have thresholds above which, and it's usually 50 kilos, above which a kid will transition to the adult. If it's a children's hospital associated with an adult hospital or a children's ward in an adult hospital, transition to more adult-based dosing. And I think that's actually true even at all children's hospitals. At just at 50 kilos and above, you just start getting a gram of this and a liter of that. The interesting thing on the outpatient side is that they've done some research showing that families with limited health literacy, which is almost everybody at some point. Like, I am very health literate, and obviously as a physician, and yet like there are some things about insurance that I still don't understand. Or if my child is the one who's currently in the emergency department for trauma of some kind or breaking an arm or whatever, I'm not going to be I'm not bringing my A game in that moment. So, but definitely families with limited health literacy, they've interviewed and discovered that they had no idea that their child was getting a weight-based dose. They have no idea what that is. It never occurred to them that their 2-year-old gets a different dose than their 7 or 10-year-old. And so it is something that's ripe for error because, to quote a family member that I was just talking to the other day, we don't know what it is we don't know. And so they have no idea that weight-based dosing is a thing. And it's one of the biggest challenges for outpatient prescribing, and it's one of the reasons that it is incumbent upon providers who write prescriptions to make sure that families understand each element of the prescription. And it's even more important, or upstream from that, it's incumbent upon the provider to understand and make sure that the provider knows what the elements of a prescription are and how they need to counsel families. Because families need to know not just the drug and why it's being given, which is another interesting thing that I think we sometimes fail to communicate with families. We say, oh, I think your son has an infection, I'm going to give him this prescription. When in fact, I think your son has an ear infection, I'm going to give him this antibiotic for 10 days. Families don't always understand that they need to take it for 10 days and then stop. But also, your son needs to get 100 milligrams of this medication, and it's going to be 5 milliliters. I mean, that's one of the things that really I wish we had a better system for. As a physician, I have to worry pretty much exclusively about dose, but the families that have to administer the medication have to worry about the dose and also the volume that dose is going to be in. And so they have to know 2 numbers, which is very confusing, particularly for people of limited health literacy. And then if you have one child getting one volume and another child getting a different one because they're different sizes, then it's even more confusing and complicated. So weight-based dosing is mandatory and what we need to do, and absolutely adds additional complexity and burden on families to understand what it is that's going on.
So we've talked a lot about acetaminophen and ibuprofen and a little bit about antibiotics. Are there other really common medications that are often misdosed? Is it just any medication that has a concentration that we have to give? Is this something we have to worry about for all of them?
Yes. It's something you have to worry about for everything. The most common ones are antibiotics, and the families typically seem to, or the literature seems to show that families seem to fall back on volumes. And so they may not understand completely the dose in terms of milligrams, but they will hang on to the volume. And so the biggest source of dosing error is families misunderstanding volume, particularly if we use vernacular. So we should never, ever, as providers, ever use vernacular like teaspoon or tablespoon to describe a dose. When we do that, the literature shows that families think of a kitchen spoon, and kitchen spoons are not standard units of measure. They don't use the teaspoon from the measuring spoon. They use their kitchen spoon. And so they did an interesting study where they measured a bunch of commercially available spoons and documented that the volumes ranged from less than 2 milliliters to greater than 9. And so if you expect someone to give 2.5 milliliters and they get 9, you've given them essentially
That's
a fourfold.
too much.
Yes.
Yeah.
Yes.
Oh
and if you do it
yeah.
one time, okay. But if you do it every time and it's a twice a day or 3 times a day medicine, then
Not great.
no.
It sort of reminds me of, there's this YouTube channel that I watch called Glenn and Friends Cooking, and he does a whole bunch of like old recipes. Like he'll literally take out an old cookbook from the 1800s and cook from it.
That's awesome.
But they'll have standardized measurements or non-standardized measurements from like Europe and France or even just like weird places in the Midwest. And he's like, well, we're just going to assume what they mean when put in a teacup worth of this. Yeah. And so every time I think about that, it's like, yeah, it's just completely non-standard. So.
I know. That's exactly it.
One thing that you were just mentioning kind of brought up a question for me, Meg, which is kind of around not just the dose that we prescribe, based on weight of our pediatric patients, but also something that I think also comes up a lot when we're starting patients on medications in the hospital, but we're going to send them home, is about sort of how many times a day the medication should be dosed.
Yeah.
And I was wondering if you could speak to that and sort of and how you conceptualize that in terms of medication error. Like, you have a medication that in terms of its ideal pharmacokinetics, it should be 4 times a day, QID or Q 6 hours or whatever. How do you kind of think about that with medication error?
So I think I put it into sort of 2 buckets. The first bucket is what we all know and familiar with as people and human beings, not just physicians. The more times a day you ask someone to give a medication, the fewer doses they will actually get. So if you have the option to prescribe a regimen that has fewer doses, if you can do something once a day or twice a day instead of 3 or 4 times a day, then you will automatically be helping to support that family be more successful adhering to that regimen. It's just so complicated. I cannot imagine trying to dose one of my children 4 times a day. I wouldn't be responsible for it half the time because half the time they're at school or daycare. And so again, that introduces more caregivers, making sure all the caregivers understand, and that's not always easy to do. So if you have the choice to limit those kinds of complicated regimens, you should absolutely do so. The second thing that you can do as a provider is use living room language. So I just told you not to do that in terms of volume, and now I'm telling you to do it in terms of schedule. If you use the traditional medication, like medical speak of TID or 3 times a day or every 8 hours, some families will interpret that as needing to wake a kid up in the middle of the night to get the 3rd dose in. And so the AAP and other institutions have recommended sort of a living room language approach to, morning, noon, evening, and bedtime, so that families understand, just before breakfast, around lunch, in the afternoon when they get home from school, and then bedtime. Or if it's twice a day, like, do you want it in the morning at bedtime, or do you want it in the morning in the afternoon, something like that. And so I would encourage using that kind of language for the purpose of schedule, and then doing everything you can to not give complicated regimens if you can avoid it.
No, we recently had that. One of my sons had pink eye, and he got polymyxin B trimethoprim, and it has to be dosed multiple times a day, and it was driving my wife crazy. She's like, do I have to make sure that am I driving to school to give him the eye drops? And it was like this whole thing, and I was like, oh my gosh, this is like horrible.
I know. So when I brought my first child home, I thought I was all set. I was a board certified pediatrician at the time. I was like, it's gonna be cake. And being a parent, I did not think parenting was gonna be cake. I did think that infancy would be the easiest part because all I had to do was keep her alive. Now that I'm negotiating like discipline and TikTok and it has definitely gotten harder. But I thought infancy would be easy, and it's just, you take the child home and you realize just how much you have no idea about, and practical strategies to get your family through the day when one or more of them need to be on scheduled medications. It was so easy to prescribe those things when I was a resident without children of my own. And now that I'm on the other side of it trying to do that sometimes, I'm like, oh gosh, I don't know how people of limited health literacy manage to get it right. It is a credit to these amazing families that they step up and learn all that they need to take care of children who are on chronic medications, because it is so challenging, and we don't make it easy. We can make it easier though, I promise.
And some of these, I imagine, extrapolate to not just the frequency of dosing, but the number of medications. I don't know if that's evidence-based, but I imagine,
oh, for sure.
Sometimes some of the med lists, when there's vitamins and bowel regimens, and, some of these medicines are very important. Some of these medicines are not that important. Do you have like a deprescribing spiel or shtick that you tell students, trainees, or families, patients?
A deprescribing shtick?
Yeah, or like a shtick on having too many medications that are not necessary.
Polypharmacy.
I don't. That's a good question. I don't have a prepared patter or shtick for that, other than to tell people that it's exactly as you describe. The more medicines that someone is on, the more likely it is that a family, that a caregiver is going to make an error, or that honestly that we're going to make an error too. For sure. So I talked a little bit about transitions of care earlier, and big transitions of care are like when someone comes into the hospital or leaves the hospital, and the medication reconciliation we do at that time is critical and is also a super likely, super common place where we get it wrong. I think one of the biggest challenges is that we have no one gold standard source for truth. So families may report one thing. The recent clinic visit note from the neurologist may describe a different regimen. The pharmacy may have dispensed something with a different prescription on it. And so you're left there trying to figure out which of those things is most accurate. But as you point out, that's also an opportunity, particularly on discharge, to deprescribe or at least take things off the medication list. The number of times I see in the hospital, because in one of my roles I end up doing my own medication reconciliation when someone leaves the hospital, and the number of times I see old antibiotic prescriptions that are left on the MedRec list from like a year or two ago, an otitis in 2018. And I'm just like, that, it's just noise. It's noise keeping us from understanding what the person really is supposed to be on. So that's a good point. I should maybe get on my soapbox about that a little bit more because you're absolutely right. The more medicines you're on, it is evidence-based. The more medicines you're on, the more likely it is that they'll make an error, you or the family. And we should all be empowered to listen when families say that they're not taking those things anymore and take it off the list.
Absolutely. And I think, one question I have for you is, what should families know about medication safety? And do you have any advice that you routinely give to families about how to kind of help them manage, regardless of their level of health literacy, about having their kids be safe with these medications we're prescribing?
Yeah, absolutely. The biggest thing that I counsel families is that their version of the med list should be the gold standard one to the best of their ability, and to treat it like a religious tract. It's gold, it's invaluable. They're the ones who know, even down to the most minute detail, like if you come into the emergency department and you have this med list, knowing when the last time the child got a specific dose. Are they due now? Are they due yesterday? Are they due later? So having that medication list and keeping it up to date and accurate is one of the most powerful ways that families can successfully communicate with the physicians that they're going to interact with all throughout the healthcare system, when those physicians may not be familiar with their child. And then the other thing that I tell families is it is my job to make sure that they understand how to safely give the medicines. And I also say it is really common that families have questions about this because it's so confusing. What questions do you have for me? And I just try and set it up like, if you don't have questions, then you must be a super genius. But, what questions do you have? And one thing that I probably don't do often enough is empower families to talk to the pharmacist when they get a prescription filled. Because I think families will often, the pharmacist will hand them the bag at CVS or whatever and say, do you have any questions? And families are just like, no, it's fine. And I'm like, no, pull out the medication, look at it, make sure you understand, because I just told you all this information about what this medicine, how we're supposed to give this medicine to your child. Make sure that the instructions on that label match what you think, because this is a whole other kettle of fish, but pharmacies can actually change the labeling information on a prescription. I don't think prescribers, this is one of those things that providers don't even know, but if you write a prescription for 100 milligrams of medication X and the pharmacy has it in a different concentration than the one you prescribed, well, the volume instructions on the bottle may be different from what you told the family in your clinic. The other thing is that you may have written a prescription for 100 milligrams of medication X or 500 milligrams, but the pharmacy can actually write 0.5 grams if they want to. And then the family was told it's 100 milligrams of this and I want you to give 5 milliliters, and now they're getting 0.1 grams of something and they're being told to give 2.5 milliliters. Families should they should feel empowered to ask questions about why it's different from what their doctor counseled them.
I think this is, I also forget to have encourage patients to talk to the pharmacy. I feel like pharmacists just in general are like one of the most underutilized, overtrained resources in all of healthcare. Outpatient or inpatient. It's not,
yes, they're so valuable. And we should lean on them heavily, especially in the inpatient world where we have such ready access to them. Lean on your pharmacist. If you don't know what a medication is, call them. If you don't understand the dosing regimen, call the pharmacist. They have access, at least at our institution, they have access to all these pieces of information behind the scenes that I've like never seen before. They can call other pharmacies and get all this back data about when a prescription was filled and how it was filled and all this stuff. It offloads. Everybody is so busy. Like, use your team. The pharmacist is just
for sure.
That person is there. They have this expertise. They went to school for a really long time. You use your expertise and then use that person's expertise.
Yeah, I feel like that's a great pearl of like using the pharmacist, outpatient or inpatient. And at the beginning of the recording, you had mentioned that there were a few things that providers can do now to prevent medication errors or save lives. And we've talked about a few, but I want to make sure that we're hitting everything. What are some of the things that you think all providers should know about medication safety, or what are some of these things that we can do and change our practice to be better about medication safety?
Yeah, great. We have talked about a lot of them, and I have a big list, but I'll try and hit the big ones. I think that both in written form when you are writing prescription and also when you're communicating with families, make sure you understand all of the required elements of a prescription or an order, and that you actually communicate that in living room language, with the exception of vernacular about teaspoons. Communicate that with families. So make sure it's complete. This is the medication. One place I think that we fail is we don't tell families indication all the time. I think we tell indication a lot when it comes to an as-needed medication, like use this acetaminophen as needed. But if we say, I'm going to prescribe this antibiotic, we just assume that the family understands why we're giving it. And so it should, this is the medication, this is the indication, this is the dose, it's going to be 3 times a day, so breakfast, lunchtime, and bedtime. I want you to give this for 10 days. I'm worried. I want you to watch out for the following side effects. And I want you to, the purpose of this medication is to help your child get over this infection. And when we are finished with this medication, you don't have to go into this detail, but like you could even tell families, like, then you throw it in the trash. A lot of families don't know what to do with their leftover medicines. So in written form and in verbal communication, being as explicit and complete as possible. And if you don't know what all the elements of a prescription are, or all the elements that need to happen in that conversation, then there's some great resources from the AAP, and or just email me and I'll tell you. The other thing that we haven't touched on, but I think is really important, both inpatient and outpatient, is logical dosing. So we talked about weight-based dosing and the fact that you might need to give 127.5 milligrams of something because a kid weighs 12.75 kilos or something. Please round. Please round to a logical dose.
Such a pet, yeah.
Not only is a parent not going to draw up 127 milligrams of anything, but not even a nurse is going to do that. So don't pretend like anyone's getting 127.5 milligrams of anything. Just give 125 or 150. The therapeutic windows are usually pretty big, but give something reasonable, something that rounds to the nearest half a cc or whole cc, so that people can do rational dosing. That is actually would be of huge benefit to helping people understand, and not require too much brain power. We said it was okay to discontinue medications. We talked about medication reconciliation. And I think that so those are the things. I have this whole list, but again, if you wanted to start doing really powerful things today, being complete with your communication, written and verbal, rational rounding everywhere for everyone's sake, and then really empowering families to ask questions early and often to make sure that the communication was as complete as you thought it was, with you and with the pharmacist, setting the expectation that everyone has questions about this stuff because it's complicated. what are your questions, and getting them out there and making sure, because everyone at some point is going to have low health literacy, either because they're stressed or because they don't speak the language you're speaking, which is another thing, but you have to communicate in the preferred language of the person you're speaking with. That is also mandatory. And so these things do take a little bit more time than you've probably been putting into it, but it doesn't take any more money. It takes a little bit more time. And it's one of those things that if you practice and make part of your muscle memory, it does get faster, and then it takes less time over the course of your career. And you will have saved morbidity for sure. And if you're, I don't want to scare people, but every once in a while, these strategies are the kind of thing that can actually save a mortality. So, as someone who has watched a kid with pretty horrifying flecainide toxicity in the PICU because of a 10-fold overdose, I do not wish that on anyone.
I always double check my flecainide dosing.
Right. Double check it, and double check the volume and the concentration. Yeah.
We have some providers in our clinic that are, I should do more, but that will take a small syringe, mark, the 3.5 milliliters for acetaminophen dosing. Although I will say now I'm a little even more hesitant. I imagine the concentrations of acetaminophen and ibuprofen in pharmacies are more standardized, but
those have actually been standardized by law. And so I don't think there's any acetaminophen product out there that's not 160 milligrams per 5 cc's.
Excellent.
But I think this concentration of ibuprofen has also been standardized, but those are like the only two.
Got it. So those are the only ones you can use the syringe marker technique.
Yeah. But so when I was a resident, one of the clinicians I rotated with used to make it part of his well child check visits. So every time a family brought their kid in for a well child check and they got a new weight and a new height and a new mark on their growth chart, he would just say, okay, so if you need it, at this point in your child's life, this is how much acetaminophen he should get, and this is how.
Oh, that's awesome!
Right? Yeah. It wasn't like didn't wait until the kid was sick for the family to ask, because there is also literature showing that families don't understand the charts on the back of the box from acetaminophen and ibuprofen, and so they can get that wrong.
Sometimes they don't ask. Like if they got a prescription for Tylenol or acetaminophen like last year, they'll just pull the same one out and give the same dose that they gave the kid who was like a completely different weight.
Right, because they have no idea about weight-based dosing, as we talked about before. And some of those, the charts on the back of some of those boxes will have the weight, but for some boxes they'll have the age instead, like age 2 to 4 give this much, age 5 and up give this much. And so anything we can do, even for over-the-counter medicines, to guide families. In fact, if you have a really critical medication, like Justin, you were talking about, like some of those medicines are really important, some less so. But if you have somebody who's, and I don't usually prescribe anti-epileptic drugs, but if something like that, literature shows that one of the best strategies in that scenario is actually to teach and show a family how much you mean when you say that I want the kid to get 150 milligrams or 5 milliliters, and show them what you mean and show them how to draw it up. And then again, I think it's really important to empower them to talk to the pharmacist when they pick it up, because it would be horrifying if the person got a different concentration from the pharmacy than what they had in the clinic, and then they leave there with a misunderstanding of the volume that should be administered. So teach back and read back, as always, as in all things, medical communication.
I think those are good reminders, especially again with the pharmacist. And I love the well child visit and doing acetaminophen and ibuprofen dosing. And actually, Chris, the one person that I've seen do that consistently was our shared resident, Dr. Kinsey Daniels, who was in Ohio and then over at Rhode Island. And so it's a good shout out to her, because that is something that I think about doing in my practice.
Yeah, and you could, you wouldn't have to necessarily calculate it for every kid. If you were an outpatient provider, you could just make a table and then print out like 100 copies, and then every time somebody came in for a well child check, you could put the kid's name, the date, and circle where they are on the table, and then you don't have, just be like, oh, it's 2022, It's time
This
for the
is a
whole
QI project. Yeah.
Yes. Oh,
Yeah.
where are the
I
med
don't know
students
why-
and residents in the
Yeah.
audience who want to do a QI project?
I mean, why can't that be done? I mean,
Yeah.
like when, back when I was doing a lot more inpatient peds, every kid who got admitted, they got a special page they got printed off with all their doses for rapid response.
Yeah.
And it was just automatically there.
Yeah, and the code sheet, we have it in the PICU too. Like if you're 10 kilos, your code sheet has, and we could we do it all the time on the inpatient side. It's so easy to do it we're just talking about 2 medicines, ibuprofen and acetaminophen. And if your kid weighs 15 kilos or 20 kilos, because again, you're rational rounding with these drugs. You don't need to give the 12.873 kilo dose. So yeah.
All right. Someone's got to do that.
Someone's got to do that.
Yes.
Audience, we've given you a project. Enjoy.
Seriously, in your copious amounts of free time.
Yeah.
And when you publish the QI, you have to cut the curbside.
Seriously.
Yeah. That's all we ask.
I think we've talked about this a bit, and I think your point of, like medical literacy is really contextual to like the moment, and it's something that we all have a variable amount of at any given point of the day or middle of the night, if it comes to that.
Right.
But I do think that, something that I've encountered is that there can be more medication errors when there are more unfilled gaps in medical literacy, or inadequate interpreter services is also, a significant problem that I've experienced. And I guess in terms of just like any advice or innovations that you've been part of to kind of help mitigate specifically these issues of inequity regarding medication safety from your perspective.
So I think the tool that comes immediately to mind, and it may not address all of what you're getting at with your question about inequity, is at Montefiore, they just published this, I think it was one of the articles I sent you actually, Becca. They published an intervention that was aimed at discharge medication reconciliation and making discharge from the hospital safer, particularly discharge from the inpatient area of the hospital as opposed to discharge from the emergency department. And their intervention was a bundle of 3 things. They educated all of the folks in the hospital about their project and what they were hoping to achieve from a communication standpoint with families. They leveraged their EMR and made a bunch of changes to that not everybody could do. But then they trained everyone in a standard form of communication around medications at the time of discharge. And it has all of the elements that we were talking about. So the acronym they used is MEDRIGHTS. So M stands for medication name. E is engage the family. By engage the family, they meant asking the family if they'd ever heard of the medication before or knew anything about it, which makes sense if you're doing medication reconciliation on discharge, and some of those medicines the child may already have been on when they came into the hospital. So you say, do you understand? So this Asthma-Nex, you've heard of this before? Are we on the same page with this stuff? Yes, no? And then dose, your dose has changed or your dose remained the same. R is for root, because to your point about healthcare literacy, if you don't explain that an antibiotic for an ear infection is supposed to be taken by mouth, some families will put it in the ear. And then there's treatment failure and the potential complications of that. The indications for taking, so this is your antibiotic for your ear infection. And again, that struck me when I read this paper as such a simple thing that I had not been doing consistently. I think we do it all the time for as needed medications. If there's pain, give this. If there's fever, give that. And we don't do it for scheduled medications, and we really should. The timing, so that's sort of like frequency. And then the side effects and storage, so keep the syringe next to the bottle, don't lose this is how you're going to be able to accurately give the medicine your child needs. And so using a standardized approach, making sure you give the correct elements to every family in the language that is their preferred language is your best chance to make sure that you mitigate outpatient medication errors. and frankly, inpatient ones. We've had lots of families catch a nurse right before a medication is about to be administered because they are seeing something that wasn't quite right. Either the timing was off or the syringe looked too full or too, and so we hear about stuff like that through our pediatric medication safety team and realize that families who actually understand what their kids are supposed to be getting are a total ally and an additional layer of safety even in the hospital.
This is great. A quick time check. I think we're perfect on time and transitioning to, I was going to start wrapping up and ask for take-home points. Anything else, though? Any other major broad topics that we feel like we need to hit on before we go to take-home points?
I don't think so. I think I think it is so important to get the basics that we've been talking about down, but if people are already doing that, then there's good evidence to support the more advanced techniques, like actually demonstrating how to draw up a medication and showing people what a syringe looks like and drawing pictures. Even this sort of gets to healthcare literacy and language barriers too, Becca, is if you draw a picture of a clock and kind of say, all right, at 0800 you give this, and then at noon, and so using those things, that pictorial reminders work really well for families with limited healthcare literacy or literacy of any kind. And so those advanced techniques are things that people can also do with a little bit of extra time, but starting today with no extra education or real investment, that can really help families get it right.
I think these are great tips, and I think these are great things that are applicable both outpatient, inpatient, and just improving communication in general. We've talked on a lot of these, like you mentioned, interventions that providers can do now to save lives. What are big picture, the main take-home points that you think are important for our listeners to leave this podcast with?
So I think I mostly touched on them, but I guess I would say, since I've been harping on communication and all the things that providers can do, I would also say that we touch on this a little bit. I think it's so important. You're not alone. Nobody's practicing medicine in a vacuum. If you aren't certain about how to communicate with a family or communicate, you have interpreters, you have video interpreters, you have family and patient liaisons. If you're uncertain about this medication or dosing or whatever, lean hard on your pharmacist, because that's all they want to talk about. They love medicines, and so use your whole team. You don't have to do this stuff alone. And then also be confident and reassured that people like me, I'm not the only one out there interested in this, obviously. There are a lot of people all across the country that are very interested in making this safer and are lobbying with the AAP to get things like universal concentrations, so that it doesn't change from inside the hospital to the outpatient pharmacy, and universal labeling requirements, and mandating that liquid medications be dispensed with a syringe. So we didn't mention this, but we were sort of alluding to it. Liquid medicines obviously are more error prone than tablets are, and are far more typically involved with errors than tablets. So please be reassured that there are people trying to do things on a much more systematic level so that we can make the system safer and easier for providers and patients.
Excellent. Thank you.
You're welcome.
And then our final question, anything that you think we should plug, or anything that you want to have our listeners check out, website, resource, anything to plug for the people that listen to the show?
Yeah. Oh, well, in terms of medication safety, I actually don't have the AAP, as always, is our source for recommendations and great institutional policies and best practices, and they do have several policies and statements around medication safety. If you don't have to take my word for it, you can read what the AAP has to say about it. And then if you're ever out on Cape Cod, do yourself a favor and go fishing, and then hit Sunday school up for some ice cream. There's one in Dennisport. There's one in Harwich. It was voted the best place to get ice cream in Massachusetts in 2021. It's super delicious.
Wow. Nice. Good plug.
Awesome.
Good plug.
Yeah.
Excellent. Well, hey, thank you so much for joining us, sharing your expertise and time. I think this is a great episode and has a lot of tangible skills that inpatient, outpatient providers at all levels can kind of walk away today and implement. So
Thank you
we really
so
appreciate
much.
having you.
Thank you so much for letting me do this. I think it's so important, and I'm so happy that I get to talk to a new audience about it. I really appreciate it.
Of course. Well, thank you for the time.
Yes.
Really appreciate it.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or your favorite podcast player. You can also email us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Dr. Becca Raymond Kolker, our executive producer for this episode, Nick Lee, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Becca Raymond Kolker.
And this has been Chris, the Chi Man Chu. Thank you. Good night. Peace.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.